Welcome, students. This is the second part of the lecture series on human immunodeficiency virus. In this part, you will be detailed about the lab diagnostic procedures of HIV. In the third part, we will be dealing with the treatment and post-exposure prophylaxis. So, primarily the objective of HIV testing is to ensure transfusion and transplantation safety, to diagnose HIV infection not only in symptomatic individuals but also among the asymptomatic individuals who are in the window period of infection, prevention of parent to child transmission for post exposure prophylaxis, epidemiological surveillance using unlinked anonymous HIV testing, and for research purposes. Before we go into the details of the lab diagnostic procedures, there are three terms which I would like you all to understand and to be aware of, because I will not be repeating these terms in the later part of my presentation. It is very well understood and it is very well implied that these terms apply for every and any diagnostic technique which is related to the confirmation of HIV AIDS in the patients. The first principle is consent. Before we even venture for HIV testing, it is very, very important to take the consent of the patient. The patient must be explained about the procedure, the risks involved, the interpretation, and the nature of the diagnostic testing. Having said this, it is very important for us to realize that consent is not required for administering the first dose of post-exposure prophylaxis regimen in the event of a needle stick injury, especially for a healthcare worker. But for the subsequent doses or for continuation of the post-exposure prophylaxis regimen in the affected healthcare worker, definitely a consent is required. Please also note that if the healthcare worker refuses to undertake the PEP regimen, or if he refuses to comply with the PEP regimen, he or she should be giving in writing that he or she is not willing to further comply with the proposed PEP regimen. This is very important for the legal documentation and for any litigation which might arise as a result of the HIV testing process. It is also not required to take a consent for the NACO 2A strategy, which involves sentinel surveillance of unlinked anonymous testing. This is done purely for epidemiological purposes and tracking, and therefore it is implied that the details of the volunteers or the patients or the community person who's willingly getting himself tested for this particular epidemiological tracking purposes, the identity of that particular person will not be revealed at any given circumstance. The second thing is, it is counseling. Now, counseling involves both pre-test counseling and post-test counseling. This is your second cornerstone of treatment for HIV AIDS. or for diagnosis of HIV/AIDS. See, most of us usually go for pre-test counseling, but we do not even offer post-test counseling. So this is very, very important cornerstone of diagnosis, because this will help the individual to prepare for the nature and the consequences of the testing. The next important cornerstone is confidentiality. Every individual who gets tested for HIV is considered to be, having the autonomy to ensure that his or her privacy is protected. So therefore, we need to protect the patient by ensuring privacy and confidentiality. The results should be directly communicated to the patient or authorized person. The communication must be done in the sealed envelope before sending it to the consultant. Please understand that no telephonic calls or fax or email reports should be sent with regard to the HIV testing results. This is because this particular infection is not only a medical illness but also has got social, moral, legal and ethical implications. Therefore, it is very, very important to protect the patient from victimization, stigmatization and discrimination. Therefore, the results should therefore be directly communicated, especially in a sealed envelope. So, consent, counseling and confidentiality are the cornerstone principles of diagnosis of HIV. Before we proceed to the testing, it is very important for us to understand the nature of the sample that is chosen to perform the lab diagnosis. In case of serological test, we prefer to have at least 2 to 5 ml of serum or plasma or whole blood. For CD4 testing or for molecular testing for both DNA and RNA, the whole blood around 2 to 5 ml is required in EDTA tubes. Again, please ensure that before drawing blood, you counsel the patient, give him or her proper instructions and make him or her comfortable. It's very important to also ensure strict antisepsis. Do not recap the needle, because you might inadvertently get exposed to the needle stick injury. Ensure that the needle and syringe which is used for blood collection is disposed in the appropriate waste bin. The plastic syringe may be discarded in the red bag, whereas the needle can be discarded in the puncture-proof container. The samples can be stored for up to 1 week in 2 to 8 degrees Celsius. But if you are going for a long-term storage, it is very important to store it at -80 degrees for up to 2 years. Suppose your testing lab is located far away from your collection center. It is vital to first ensure that the sample which is collected is transported appropriately in what is called as the triple packaging system. The transport of infectious substances basically requires a triple packaging system which comprises of 3 layers. You have a primary receptacle, which is a leak-proof receptacle containing the specimen. It should be ensured that this primary receptacle does not have any cracks or leaks. It must be preferably made of plastic and must be screw capped. The receptacle is packaged with enough adsorbent material like sponge to absorb all the fluid in case of breakage or spillage. This primary receptacle must be sealed in a plastic or a Ziploc bag before it is put into a secondary receptacle or a leak-proof container. The secondary packaging is a durable, watertight, leak-proof packaging system to enclose and protect the primary receptacle. Several primary receptacles or several samples of the test tubes or the patient samples, if it is present, they may be placed with sufficient additional adsorbent material used in between them so that all the fluid can be absorbed in case there is a leak. Now, this secondary receptacle is now placed in a cardboard or canister box. The cardboard or canister box, you should make sure that during packaging, the tubes containing specimen should be placed in a tube rack and packed inside a cooled box made of plastic or thermocol with cold refrigerated frozen gel packs placed below and on the sides of the tube rack. It's also important to place some cotton or other plugging material between the tubes to ensure that they do not move or rattle during the transit. Outside the secondary receptacle, it is important to have the outer packaging or the third receptacle. This outer packaging is done in a suitable cushioning material. The request slip containing the patient details must be placed in a Ziploc plastic bag to prevent smudging or spillage, and it must be stuck on the outside of the secondary receptacle. The secondary receptacle should also contain an itemized list of contents present in the transport package or the shipment package. The outer receptacle should contain several details, chiefly the UN number. The UN or the United Nations number 2814 must be present on the outer receptacle. This is in accordance with the International Air Transport Association or IATA regulations. As per the IATA regulations, HIV belongs to infectious class 6.2 substances under UN number 2814, which contains several organisms which affect humans. This infectious substances should be transported in a form when exposure to it occurs is capable of causing permanent disability, life-threatening or fatal disease in otherwise humans or healthy humans or animals. So all these organisms which will cause disability, life-threatening or fatal diseases are given this UN number 2814. So this UN 2814 number must be placed on the outer receptacle. Along with that, you should have a biohazard sign. You should mention the consignee's details. Both the sender and the receiving lab details must be entered. So this is how we transport the specimen. So you have a primary receptacle, which is the specimen, surrounded by a secondary watertight receptacle and a tertiary or a third rigid or receptacle, outer packaging receptacle, which is placed in an outer shipping packaging along with suitable cushioning material. This outer packaging protects contents from outside influences during the transit. Each complete package, once again I repeat, is normally required to be marked, labeled and accompanied with proper shipping details that is available as of the from the concerned lab or the concerned testing center. So now we have collected the sample. Let us see what test can be done. The most important test that is usually done is the serological test. And the serological test which are available to detect HIV is your ELISA test. If you look at the basic testing methodology or processes of HIV infection, you can classify them into three groups. You can have screening tests, there are supplemental tests, and there are confirmatory tests. So right now we are dealing with the screening test. ELISA, enzyme linked immunosorbent assay, usually takes less than 2 to 3 hours, and rapid tests, which are also the screening test, take less than 30 minutes for giving the result. Now NACO, or the National AIDS Control Organization, the authority for formulating the guidelines for lab diagnosis of HIV and also post-exposure prophylaxis and treatment strategies, recommends the use of ELISA and rapid kits with a sensitivity of greater than 99.5% and a specificity of greater than 98%. So there are different types of ELISA testing methods which are available. The most commonly used is the indirect ELISA method. Now, indirect ELISA method, as you all know, is a technique where HIV antigens are covalently attached to the solid phase support. This allows the HIV antibodies present in the specimen to bind. These bound antibodies will be subsequently detected by enzyme labeled anti-human immunoglobulin along with a specific substrate system. Now, if the test specimen contains the anti-HIV antibodies, a colored reaction will take place. So this is the most commonly used method, which is called as the indirect ELISA method. Then we have a competitive ELISA method. In this method, both the specific antibodies to HIV in the serum of an infected person and the antibody which is present in the conjugate, so both this antibody and this antibody will be added at the same time. Both these antibodies compete for the attachment sites on the antigens that are immobilized in the solid phase. In the absence of a specific anti-HIV antibody or in a non-infected person, the conjugate will bind than the serum sample, because obviously there will be no antibodies in the person. But in the presence of an anti-HIV antibody in an infected person, only a little conjugate will bind. This occurs because anti-HIV antibodies in the serum of an infected person will bind more firmly and will have a higher affinity for the solid phase antigen. Consequently, in the sample from an infected person, there will be less or no color development because the conjugate cannot bind and thus is not available to react with the substrate. So, in an infected person, there will be no color formation. Conversely, the specimen containing little or no HIV antibody, more conjugate will bind to the solid phase antigen and the subsequent addition of substrate will cause more color development. Therefore, the amount of anti-HIV antibody in the specimen is inversely proportional to the amount of color produced, and the OD value or the optical density values, low OD values are associated with infection, and higher optical density values are produced when testing a person who's not infected. So that is the second method. Then you have what is called as the sandwich ELISA. So this is a modification to basically improve the sensitivity and specificity of the indirect ELISA. So in the first step, the antigens bound to the solid phase will bind to the antibodies which are present in the test sample. Now, since you all know that the antibody molecules are bivalent or they are multivalent, they are still able to bind to another antigen. So in the next step, the similar enzyme labeled HIV antigens will be added. Though this will be attaching to the antibody molecule, okay, which is already bound to solid phase antigen. So therefore, this antibody gets sandwiched between the two antigens, okay. So in the next step, you add the specific substrate, and the substrate will result in the color development once the complex is formed. This color, like in any other ELISA testing, is measured with the ELISA reader as optical density units. One advantage of sandwich ELISA is that all classes of HIV antibodies can be detected, and antibody sandwich ELISA that can detect P24 antigens are also available. Then you have the antigen and antibody capture ELISA. So here what happens is that we have specific monoclonal antibodies directed against NHIV antigen, which is bound on a solid phase. Okay, this is the solid phase. So in the next step, you add the HIV antigen, which is supplied as a reagent. This reagent will be captured by the monoclonal antibody. Now the test specimen which has been diluted is added next. So if the patient's serum contains the HIV antibodies, this will bind to the HIV antigen. And remaining test or the remaining step is similar to that of the indirect ELISA. Now the advantage of antigen capture ELISA is that it is more specific than an indirect assay which detects the antibodies, and antibody capture assays were developed to test specimens with lower concentrations of HIV antibodies or to detect a specific class of antibodies like IgG class or IgM or IgA class of antibodies. Okay, so each kit manufacturer of ELISA testing has devised a method of calculation which produces a cutoff value. So any cutoff value that a patient sample value which goes above the cutoff value will be considered as positive, and that below the cutoff value will be considered as negative. And there is a calculation to do this cutoff value, and you have the controls present in the ELISA kit itself, so by which you can test whether you have done the procedure properly or not. Now we have to understand here that there are some factors which can affect the ELISA test result. If the sample is hemolyzed, grossly lipemic sample, if the samples or reagents are contaminated or improperly stored, then it will give a false result. Similarly, the procedural errors like pipetting errors, improper washing, carrying over, equipment malfunction, etc. will also have their own adverse effects on the test result. Similarly, transcription errors after doing the testing is also very, very, very important, because we have to be very careful about the patient's name that we are entering in the the automated system or in the handwritten envelope. So wherever it is, so when you enter the patient's name, you have to be very, very careful when you write the results, test results. Now there are certain pitfalls with ELISA testing. Sometimes you get false positive reactions in autoimmune diseases, alcoholic hepatitis, primary biliary cirrhosis, leprosy, and multiple pregnancy. There can be false negative results when there are, as I told you, technical errors when the patient is in window period. Fortunately, nowadays we have lot of ELISA kits which are 4th generation kits. That means they test not only the antibodies to HIV-1 and HIV-2. HIV-1 and HIV-2, both the IgM and IgG, but they also detect the P24 antigen, okay, by using a combination of recombinant or synthetic peptides and monoclonal antibodies. So right now we even have 5th generation ELISA kits which can differentiate between HIV-1 and HIV-2 antibodies and also detects the HIV-1 P24 antigen. So another condition where you have false negative result is when the patient is co-infected with hepatitis C virus. The patient is undergoing immunosuppressive therapy in congenital immunodeficiency, and if the patient is infected with HIV-2 virus or HIV-1O group or outlier group of the virus. So what do you see? You detect the P24, GP120, GP160 and GP41 antigens of HIV-1 and GP36 antigen of HIV-2. Now let me take you to the next set of screening tests, which are also called as the rapid test or point of care test, because they can easily give you results within a fraction of 30 minutes. Now this is a dot blot assay. As you can see, this is a solid immunoassay where you mobilize the HIV antigens on a porous membrane and you pass the specimen and the reagent through the membrane, and if both the specimen and the reagent are getting absorbed into the underlying adsorbent pad. Now once the specimen passes through the membrane, if the HIV antibodies are present, they will bind to the antigen, and the conjugate binds to the Fc portion of the antibodies and produce a distinct red colored dot against a white background. So in this particular picture you can see that this red colored dots. A negative test result is when you get only one dot. Okay, negative test result is when you get only one dot, which corresponds to the control C, this reagent here. Okay, and positive test result you can interpret by the appearance of two dots. So one dot will appear for the control and the other one will show either the presence of HIV-1 or the HIV-2 antibody. It depends on the the type of the infection that has occurred, and specimen sometimes can be reactive to both the HIV-1 and HIV-2 antibodies, as is shown in this particular picture. Now it is very important that you get the control dot always whenever we do a test, because if the control dot is not present, this test should be considered as invalid. Okay, because that means that you have not done the procedure properly. All right, now we go to the next rapid test. The next one is called as the immunochromatography test. Now in this particular test, these are done on certain strips or certain cards. This card or the strip incorporates both the antigen and the signal reagent in the nitrocellulose membrane strip. Now once the specimen is added to the adsorbent pad on the kit, it migrates through the strip and combines with the reagent. This addition of the specimen is usually followed by a buffer reagent. So a positive reaction will result in a visual line on the membrane where the HIV antigen has been incorporated. You will get lines like this. And a procedural control again is also incorporated into this strip. Okay, so this is also very, very important. Again, if you look at the interpretation, so you have different areas marked. The control band area is marked as C. The place where the HIV-1 antigens are immobilized is marked as HIV-1, and for HIV-2 it is HIV-2. HIV-2 antigen, it is HIV-2. So positive result is one where in addition to the control band C, you will get a test band. Okay, you will get a test band which is appearing either in the region for HIV 1 or which will appear in the region of the HIV 2. Sometimes, like in the dot blot assay, you will get the patient situation where both HIV 1 and 2 bands will appear. As I mentioned previously, even in lateral flow assay, this control band should always be seen. If it is not seen, the test is considered as invalid. So all these two tests are considered as invalid, because if you see, you are not getting the control band here. Okay, right. Then the next one is called as the particle agglutination assay. Now, agglutination assays are usually used for antibody detection. Here the antigen, as you must already have been knowing, is coated on a carrier particle, and once the antigen antibody reaction occurs, you can see clumps. Now, these assays incorporate various carriers like RBCs, latex, gelatin particles or microbeads, and during an agglutination reaction, an HIV antibody combines with the antigen on the carrier particle. So this structure can be macroscopically visualized. See, like this. This particular figure actually depicts the results of an agglutination test. So if the specimen contains antibodies, lattice network will form between the antigen and the antibody and will be seen as clumps like this. Okay, so this is a reactive sample. In the case of a non-reactive sample, you will not get any clumps. So here the samples are not reacting, here it is reacting. Okay, so that is about the particle agglutination test. Now we come to what is called as a dipstick or the immunocomb assay. Now the immunocomb assay is a rapid assay where you are trying to differentiate between HIV-1 and HIV-2 antibodies in human serum or plasma. So basically this comb is called so because of comb-like device and because of these projections. Okay, sorry. Yeah, so you can see the projections here. So these are what are called as the combs. Okay, so each tooth of the projection represents a solid face and has got 3 spots where the specific antigen or antibody is adsorbed. Both the HIV-1 and HIV-2 are immobilized as circular spots at 2 sites, and the third spot acts as an antibody control containing goat anti-human immunoglobulin. This test is carried out by sequentially immersing the comb in wells with ready-to-use reagents. So when the comb is incubated with a sera containing HIV antibody, these antibodies bind to the antigen which is present on the comb, and the complex is visualized after addition of the antibody enzyme conjugate and the substrate. So this is how it is seen. Again, like in the other rapid assays, you have a valid test and an invalid test. Invalid test will result when there is no upper spot here. Okay, and this is a valid test where all these are valid tests where you can see the control spot is present. Now if HIV-1 is only present, antibody is only present, only this spot will be seen. If HIV-2 is present, only this spot will be seen. That is HIV-1 you will have the upper spot, HIV-2 you will get the lower spot. If both the spots appear, that means you have all the three both HIV-1 and HIV-2 are present in this particular patient. So you call it as reactive. Okay, you call it as reactive. Right. So this is about the rapid testing and the ELISA testing. Please remember that we always use these two terms whenever we deal with these ELISA tests: sensitivity and specificity. Remember, sensitivity always detects true positives and specificity always detects the true negatives. Okay, so even if little amount of antigen or antibody is present, the test will become sensitive, and we can confirm it further. All those tests which has got good specificity, you can definitely confirm whether HIV 1 or 2 is present or not. So if you can just look at this sensitivity and specificity of the different screening tests, that is the ELISA testing, indirect sandwich and competitive ELISAs, and agglutination, comb test, chromatographic membrane and flow through membrane, all of them are having an excellent sensitivity, 100% sensitivity, and the specificity slightly varies but still way above 98% as per the NACO guidelines. Please remember that throughout this presentation I have referred materials of national guidelines for HIV testing year 2016 as prescribed by the National AIDS Control Organization. So then we have the supplemental test. Now what do we mean by supplemental test? It just supplements the screening test. So once the person is detected to be positive in any of these screening tests, we go for the supplementary test. Now in supplementary test, we perform what is called as the Western blot test. Here various specific HIV recombinant or synthetic antigens are adsorbed onto a nitrocellulose paper, as you can see here. Okay, so it can get adsorbed onto the nitrocellulose paper. Suppose the antibody is present, it will get attached to the antigens which are coated on the strips, and the antigen antibody complex is formed. Now this antigen antibody complex is detected by an enzyme conjugate and substrate similar to what is done in an ELISA, except that this product is insoluble. Okay, so the Western blot test will detect the presence of antibodies against specific HIV proteins, and each of these proteins, if it is present in this particular serum sample, are noted as bands. You can see different bands are present for each of these proteins, and these bands, if it is seen or if it is visible, okay, it means that this particular protein is present, and the test results are usually interpreted as per the manufacturer's instructions. But for a general guideline, what we generally have, general guideline is that as per the WHO criteria, we require that for labeling a person as HIV positive by Western blotting, we require that the patient should have 2 of the ENV bands which code for GP120, 41 or GP160 with or without GAG and Paul bands. Okay, so WHO criteria says 2 envelope bands should be present with or without GAG and Paul bands. The GAG band is GP55, 40, P24 and 18, and Paul is GP68, 53 and GP32 band. Now the CDC criteria is slightly different. It says that any 2 out of P24, GP120, GP160 and GP41 band is enough for us to label this particular patient as HIV positive. Now in our different labs, they use different criteria. In this part of the world, we may follow the WHO criteria. So as you can see in this particular illustration, this is your control strip, okay, and this is your negative control strip, where you can see the control bands are flag positive. That means you have done the test right, and these are the positive bands for HIV-1 and HIV-2 respectively. Okay, so this is your supplementary test. Now, along with the supplemental detection or the detection of HIV using the supplementary test, it is very, very important to detect the P24 core antigen, because the P24 antigen becomes detectable after 12 to 26 days of infection and lasts for 3 to 4 weeks. Again, you can see here, this is the P24 antigen. Okay, so this is the timeline of infection, and you see here P24 is antigen is detected in this early stage, and again in the later stage also you have the P24 antigen which is detected. Okay, so usually this antigen is detected, as I mentioned earlier, by a fourth generation ELISA. Now, what are the uses of P24 antigen detection test? It is used to confirm a diagnosis of HIV/AIDS, especially during the window period. It is a very valuable test. You already know now that window period is a phase where the patient will be asymptomatic but the virus will be replicating. So in such a situation, the P24 assay is very important. It also helps in diagnosing the late stages of HIV/AIDS or CNS disease. It helps us to monitor the progress of HIV infection and also to resolve any equivocal results which is obtained from the Western blot. So whenever you have multiple bands, or if suppose in the Western blot test the bands appear very faint in spite of appearance of control bands, so you are in a sort of a gray zone area where you need to, you will be in a fix to label that particular person as positive or negative. So therefore we need to do this P24 antigen assay to resolve such equivocal Western blot results. Then what we do is we go for molecular testing. Now molecular testing can be done, that is the polymerase chain reaction or a PCR reaction can be done. It is very extremely useful test. Okay, please understand first that you can detect both the RNA and the DNA. And among these two, the detection of viral RNA is considered as the gold standard method for confirmation of HIV diagnosis. So whenever a test is called as gold standard, that means it is very sensitive and specific method and is the best method for confirmation. So if this test is positive, definitely the person is having a HIV infection. So this testing method can diagnose window period. It can monitor the viral load, especially following the treatment, and also it can monitor the response to antiviral therapy. It can also detect different genotypes and can also detect drug resistance. So you can see the multitude uses of detection of the viral RNA. Okay, now you can detect viral RNA by two methods. Either the target is amplified or the signal is amplified. If the signal is amplified, you can do it by a technique called as branch chain DNA technique. Now that if the target of the amplicon or the desired product is visualized, then you can achieve the target amplification by doing reverse transcriptase PCR, real-time PCR, and nucleic acid sequence based amplification. Okay, please understand all these three are three different techniques. Okay, now for viral DNA detection, you can do it especially for diagnosing pediatric HIV infection. Okay, please remember this. For pediatric HIV infection, detection of the DNA PCR is very important. It differentiates also between the latent and the active viral infection, and also you can diagnose it in the window period, estimate viral load, and detect the genotypes like how you can do for your RNA PCR. But DNA is especially very useful for detecting pediatric HIV infections. Okay, so because of this prevalence of this COVID-19 pandemic, this word RT-PCR is become quite popular now. So please understand, your reverse transcriptase PCR and real-time PCR both are two different components. See, you all know that in a PCR you have three steps. Okay, so in a real-time PCR, what happens is you will be able to continuously measure the PCR product during each cycle of the PCR. Okay, as and when the desired target is detected or the target gene is isolated, the fluorescence will be increasing. So you can actually observe the increasing fluorescent or the continuous fluorescent measurement of the amplicon or the desired target is possible in real-time PCR. whereas the reverse transcriptase PCR, once the complementary DNA strand is synthesized from the sample, then you go by the standard PCR amplification and you do a gel electrophoresis of the components of the PCR, and only then you can quantify the end product. Okay, so for a reverse transcriptase PCR, you need to wait till the complete reaction gets over. But for real time PCR, you can visually see the enlarging or the fluorescence of the amplicons as and when the test is proceeding, or as and when the test is being conducted. Okay, now for diagnosing window period, this is another very important phase in the HIV infection. Now for diagnosing window period, we can use three tests. You can use a third generation ELISA kit, fourth generation one, and a RNA PCR. You can see, especially if you have a needle stick injury or things like that, usually healthcare worker gets panicked. Okay, for such people, you can have the only fact, especially in the patient or the source is in the window period, it becomes even more complicated. So how do we diagnose the window period infections? You can use these three tests, but you see, HIV RNA detects the earliest. Within 10 days it will detect the PCR can be done. Okay, within 10 days it will be positive. If it is within 12 days, 12 to 26 days, you can detect the P24 antigen by a fourth generation ELISA, and by 22 days you can detect with the third generation ELISA. Okay, now we come to the other important component, okay, of diagnosing pediatric HIV infections. Now for diagnosing pediatric HIV infection, what is the hindrance is that the routine screening methods will detect the IgG antibodies. Now problem is, you cannot be sure whether it is coming from the mother or from the baby. So it cannot be used for diagnosing the pediatric HIV infections. Now, as all the maternal antibodies would disappear by 18 months, therefore IgG assays can be performed after 18 months of birth. So DNA PCR is the most recommended method. Okay, and the babies tested for HIV DNA PCR, please keep this in mind, HIV is tested by performing DNA PCR. Presence of HIV can be tested by performing DNA PCR at 6 weeks by dried blood spot collection. If it is positive, then it is reconfirmed by a repeat HIV DNA PCR, and then only it is reported as positive before initiating the baby on lifelong antiretroviral therapy. The other methodologies for pediatric HIV infection diagnosis: P24 antigen, HIV RNA detection, and IgG ELISA performed after 18 months. In the case of breastfed children, it should be remembered that HIV DNA PCR should be performed 6 weeks after cessation of breastfeeding. Now, viral culture. Viral culture is usually kind of not done quite frequently, but it is very important to be aware of how we detect the virus, okay, by the culture. Now the culture method, for doing the culture method, what we do is, we have a direct method, we have a co-cultivation method. In the direct method, okay, what we do is, we do peripheral blood mononuclear, we do peripheral blood mononuclear cells. Okay, sorry for that break. We do what is called as peripheral blood mononuclear cells. We take it from the patient and they are cultured in vitro in the presence of PHA, which is called as a phytohemagglutinin. Then you have the co-cultivation method. Here we take these blood mononuclear cells from the HIV uninfected donor, okay, and we stimulate it with this PHA mitogen, and after 72 hours we culture it along with the mononuclear cells from the patient. Now the viral growth is detected by the formation of syncytia, okay, by the syncytia formation, and also it can be detected by the presence of the P24 antigen or reverse transcriptase enzyme, okay, or we can do immunofluorescence assay to detect the viral antigens in the infected cells. Now HIV cultivation is predominantly used only for research purposes. It is available only in very few reference labs and a lot of technical expertise is needed. Another drawback is it's very time consuming. It takes more than 6 weeks for us to give us the result, and it has got a very poor sensitivity due to low infective cells in the sample and low number of available cells. So therefore we generally do not perform the viral culture on a routine basis. Okay, what we generally do is we generally go by the your ELISA testing, and we do the rapid test, and we do the Western blot test and the PCR. Please also remember that there are some labs which substitute ELISA testing with ELFA or CLIA. ELFA stands for enzyme linked fluorescence assay. So just like you get the colored end product in ELISA, in ELFA you get the fluorescence, and CLIA is produced as light. Okay, there is a chemical reaction giving rise to light. And along with that, a small mention of the non-specific immunological test. So far we have talked mainly about specific testing. So in non-specific testing we do the CD4 count. So please remember that the CD4 cell count is usually carried out by what is called as a flow cytometry method. You can assess the risk of opportunistic infection, and also you can initiate the antiretroviral therapy. But however, the current guidelines say that regardless of the CD4 T cell count, you have to start the treatment, and also it is used to monitor the response to the antiretroviral therapy. So this particular table gives you the basic timeline or the infections that are usually considered depending on the CD4 cell count. So if it is more than 500, it is community acquired organism. Between 200 to 500, you have tuberculosis. Less than 200, it is Cryptosporidium candida, fungal pneumonitis, Pneumocystis jirovecii. Less than 100, you have the parasitic infections like toxoplasmosis, candida, herpes simplex or cytomegalovirus. And less than 50, again it is cytomegalo, cryptococcus, mycobacterium avium, okay, and primary CNS lymphoma. So these are the non-specific tests, and along with that there are certain markers which can be again non-specifically used to detect HIV. Usually it is not done, but sometimes it is done. So neopterin is one such marker which is present in urine and serum. It's a product of GTP catabolism derived from macrophages and B cells stimulated by interferon gamma. It is the early marker of HIV infection, and it is quite non-specific. Then you have the low molecular weight beta 2 microglobulin, which forms a part of the light chain of class 1 MHC antigen on the nucleated cells. Again, it is a non-specific early marker of HIV infection. So for dear students and all the listeners, this concludes the first part of the diagnostic testing. In the second part, we will be dealing more with the NACO strategies, the needle stick injuries, and the antiretroviral therapy. Thank you for your patient listening.